Good afternoon, everyone. Let me briefly tell you about my PhD thesis. I'm working on novel therapeutic approaches in sleep-related breathing disorders. My name is Bardóczi, and I'm a pulmonology resident in the Department of Pulmonology at Semmelweis University. During my work, I meet many patients who are dealing with sleep-related breathing disorders, which destroys their quality of life. So I would like to improve on that, and our research team working to find the best therapy to reduce the symptoms and the severity of the disease. As you can see, I'm working on 2 projects currently which address to this problem. My first project is investigating the effectiveness of GLP-1 analogs in obstructive sleep apnea patients. It's a systematic review and a meta-analysis. Obstructive sleep apnea is a serious sleep disorder that involves the upper airways collapse during sleep. 1 out of 4 people are affected, and it has several negative health effects, including the early death. Obstructive sleep apnea severity is measured with the apnea-hypopnea index by counting the numbers of apneas and hypopneas during sleep. This table shows the classification based on the severity. In the several cases, the most commonly used therapy is the CPAP device. The major risk factor of obstructive sleep apnea is obesity. 58% of the cases are linked to excess weight. Therefore, weight loss is also recommended for this patient as a treatment. Fortunately, we have some novel pharmacotherapy choices for them. I think most of you have already heard about the glucagon-like peptide-1 analog. These medications can regulate your appetite, can reduce adipose tissue while your muscles don't decreasing. This diagram below shows how the drug was effective to reduce in body weight. But how the GLP-1 analogs help in obstructive sleep apnea? We know weight loss is recommended for obstructive sleep apnea patients, and we know the GLP-1 analog can help with weight loss. So this is one way. Furthermore, they can improve the airway collapsibility and has direct airway action. And this study shows how the drug is effective to reduce the disease severity. But unfortunately, these medications haven't been implemented in the clinical practice yet. So our aim is to investigate that the GLP-1 analogs are effective treatment choices in obstructive sleep apnea. So our clinical question is, can GLP-1 analog reduce the apnea-hypopnea index, thus leading to improvement in obstructive sleep apnea patient? Our patient population is obstructive sleep apnea patient, and we want to compare the GLP-1 analogs with the standard of care. Our primary outcome is the apnea-hypopnea index, and our secondary outcomes are body weight and body mass index. And our hypothesis is that the GLP-1 analog reduce the apnea-hypopnea index, and our clinical implication is weight loss therapy with the GLP-1 analogs as a standard of care for patients with obstructive sleep apnea patients. So here you can see my finalized search key. I did my search in last year, November, and I repeated it in this year, the end of June, in 3 different databases. After the flowchart of selection, we have 5 eligible full text, so now we can move on my result. In my first figure, you can see the overall changes in apnea-hypopnea index before and after the treatment. In this forest plot, you can see 6 randomized control trials, which included over 500 patients. And the mean changes of the apnea-hypopnea is over 14, with the confidence interval of the mean falls within this range as shown in the red box. Based on this, our results are mathematically significant, but based on the table, it's not only mathematically, it's clinically significant as well. My second figure, you can see the changes in the apnea-hypopnea index between the intervention and the control group. In this case, you see in my forest plot 5 randomized control trials, which included almost 1,000 patients, and the mean difference was the apnea-hypopnea changes is over 11.5. A confidence interval of the mean difference falls within this range, so we can say our results are mathematically and clinically significant result. Now we can move on the changes in the body weight after the treatment. In this case, you see 4 randomized control trials, which included over 800 patients, and the mean difference of the change in body weight of the decreasing, it's over 11 kilograms, and the confidence interval of the mean difference falls within this range. As you can see in the red box, so we can say our results are mathematically and clinically significant. And in the last figure, you can see the change in the body mass index between the intervention and the control group. In this case, the you can see 3 randomized control trials included over 500 patients, and the mean difference was over 1.5. And the confidence interval of the mean difference falls within this range, as you can see in the red box. So our results are mathematically and statistically significant. So we have some strengths. We work only randomized control trials with a clinically important follow-up time and only 2 GLP-1 analogs. It's good because we know which is the 2 drug we can recommend for our patients, but we have some limitations. It's a small study numbers, but it's a very novel field of research, relatively small population. We work, and our limitation is we only know 2 GLP-1 analogs can work, but we don't know how the other GLP-1 analogs work in obstructive sleep apnea patients. So our conclusion, the GLP-1 analogs significantly improve the apnea-hypopnea index and reduce the severity. So our conclusion for practice, use GLP-1 analog as a standard of care, and our implication for research, we need more comparative randomized trials would further to optimize the therapy, and we need higher numbers of patients to reflect the real-life prevalence. So here you can see my first project progress, and we want to publish the Sleep Medicine Reviews, which is a D1 journal. And now we can move on my second project. My second project is comparing the effectiveness and safety of positive airway pressure therapies in Pickwickian syndrome, which also a systematic review and meta-analysis. But what is Pickwickian syndrome? Pickwickian syndrome was named after one of Charles Dickens' famous character, Mr. Pickwick, who has some typical features like obesity, snoring, dropsy, and always sleepy. But what it's mean clinically, last few minutes I talk a lot about the obstructive sleep apnea, which is a serious sleep disorder that involves the collapse of the upper airways during sleep. And here comes another sleep-related breathing disorders, the obesity-hypoventilation syndrome. These patients are obese, they are hypoventilating during sleep, and because of that they have daytime hypercapnia and hypoxemia. When the patient have both together, we can call them Pickwickian syndrome patients. Without treatment, they get serious complications like high blood pressure, right-sided heart failure, pulmonary hypertension, depression, and 4-fold increase in mortality risk, so we have to treat it. We usually treat it with positive airway pressure therapy, and our meta-analysis, we want to compare the CPAP with the BPAP machine. But what is the difference between them? The CPAP therapy stands for the continuous positive airway pressure. It's a single set pressure, blows constant pressure when you're breathing in and the same pressure when you're breathing out. It's not as great for accommodating changes in breathing, but more affordable and simpler to use. The other one, the BPAP therapy, stands for the bilevel positive airway pressure therapy. It's a 2 distinct pressure therapy, blows higher pressure when you're breathing in and blows lower pressure when you're breathing out, often used to treat more complex sleep and breathing disorders, but it's less affordable and more complex to use. So our aim is to investigate that the CPAP devices are an effective treatment choices in Pickwickian syndrome patients. So our clinical question is, can CPAP therapy be an effective treatment choice for Pickwickian syndrome? Our patient population is Pickwickian syndrome patient. We want to compare the CPAP with the BPAP machine. Our primary outcome is the arterial blood gas parameters, and we have several secondary outcomes like mortality, hospital research utilization, respiratory function, sleepiness, quality of life, and safety as well. So our hypothesis is the CPAP treatment is an effective treatment choices for Pickwickian syndrome, and our clinical implication is CPAP treatment is an effective first-line treatment for patients with Pickwickian syndrome. So here you can see my preliminary search key. We found 3 K articles, and my first project progress, it's here. My project seems feasible, and our Prosper registration is on. We wait for the submitting my Prosper registration. And I would like to say thank you for your attention with the word of famous physicist George Gamow. Science is not just about knowing things, it's about asking the questions and pushing the boundaries of that knowledge. Thank you.
Congratulations. I would like to ask one question and then give the microphone to others. There was no difference at all between the 2 GLP-1 analogs studied by you, so the results were very, very similar, or one was a little bit better than the other?
Yes. We investigated in liraglutide and tirzepatide, and the tirzepatide it's way much better than liraglutide, we found that. But the tirzepatide topic came in this June. So the article published in this June. So this is why we have to repeat it, my whole selection process. And this is why, but tirzepatide it's a way more better than liraglutide for the obstructive sleep apnea patient.
Other questions from the audience or from co-chairs?
Thanks for being again here. It's both privilege and pleasure. And I need to disclose that I'm also a clinical pharmacologist, and my passion is also lung medicine. So a couple of suggestions and questions, and I also do the body composition things and like that. So the first thing you need to know that GLP-1 agonists and SGLT2 inhibitors, they both reduce body weight, but we still don't know what do they reduce. Apparently, it's also the loss of muscle mass. So I would humbly disagree with your statement that this is clinically important because you don't show the quality of life results for the patients. So they reduce AHI, but we don't know whether they improve quality of life. Because if you are losing body skeletal muscle, then your quality of life usually worsens. So that is something that we still need to sort out. So that is with regards to your first one. So if you could get the grip of the body composition data or quality of life, that would strongly enhance your message. Now the studies, in particular in heart failure, are doing body composition because of that fact. For the second one, in Pickwick syndrome, you don't know whether it's obstructive or central. In central, masks are worsening the prognosis. They are increasing mortality. So you need to be careful in teasing that out. We were at the start of the project. SURF-HF has shown that in heart failure, that using a mask, cerebral ventilation, increases mortality. So please be careful when you do the analysis on that. But here I read that you also planned a randomized control trial, which you didn't show, but that is the message for everybody, that when you're doing systematic review and meta-analysis, the end result should be a randomized control trial based on what you have found in systematic review and meta-analysis. And for your colleague, I think it's not feasible, but for you maybe, because you, in first project, you had only 5 studies. The ultimate aim should be individual patient data meta-analysis, if possible. That would be ideal, because then you really can make the very strong statements for the future. Thanks.
Thank you.
Congratulations.
There are 2 questions.
Sorry. I have a short question. Do you know any data about prevalence or the number of people who are affected with the sleep apnea, or any percentage, how many percentage of the population are affected with sleep apnea?
The study says it's 1 out of 4 people worldwide. It's higher than the higher income countries and lower in the lower income countries, but it's strongly depends on the obesity, because most of the patients are obesity-related obstructive sleep apnea in Hungary currently. This is the most of the top one of the reason. So.
Okay. Thank you very much.
I was wondering about, did you investigate the safety of GLP-1 analogs? I didn't see an outcome.
Yes,
you know the side effects, because we know that they could have serious side effects.
Yes, it's always, every time I'm present here, it came up why we don't investigating the safety, and it's because we don't have enough data. Only 2 articles write down the safety parameters.
But you mentioned it in the systematic review part of your manuscript?
Yes.
Okay, thanks.
Congratulations for the nice presentation. I just wanted to ask if how did they standardize the control group regarding or besides the pharmaceutical treatment, like calorie restrictions or body exercise? what's the standard of care for
Yes,
such a patient?
This is why we call it standard of care, because some articles, both of the group use calorie deficit and use exercises. Some of the articles, one of the groups get the GLP-1 analog, one of the group get the placebo and do not get the CPAP or something. And sometimes they get the CPAP, and get the GLP-1 analog. So it's really different in every article. So this is why we call it the standard of care, and the other hand with the GLP-1 analog therapy. So we can combine this. We don't have enough data.
Okay, thank you.
This.
Just one more question from the floor.
Yes, I'm lurking here in the darkness. Thank you. Just generally about Pickwickian syndrome. So for me as a lay person, it's really hard to distinguish simple obesity and Pickwickian syndrome, because somebody has like obstructive sleep apnea, maybe he or she is like sleepy all day long. So who diagnoses Pickwickian syndrome? Is it your general practitioner? Are they educated enough to distinguish between obesity and that Pickwickian syndrome exists and how to diagnose? Is it easy to misdiagnose, or is it like, so could you please tell a bit more about the difference between being simply fat and having Pickwickian syndrome? Thank you.
Okay. I'm only a resident, so I can speak about what I see in my practice. For the obstructive sleep apnea, the most patient came from the somnologist group. And what about the obesity-hypoventilation syndrome? The most of the patients go for the ICU department. And this is why we're investigating the CPAP devices, because a lot of the patients don't do the polysomnograph to diagnostic. They have only obesity-hypoventilation syndrome, or they have Pickwickian syndrome with an obstructive sleep apnea, because when the both of together, we can call them Pickwickian syndrome. And all of the patients who are obesity-hypoventilation syndrome, they give the BPAP therapy, which it's limiting the patient's everyday life, because yes, I know the CPAP is not have every problem, but some of the cases they don't try even the CPAP machine.
So it very well can be that in your GLP-1 studies there were some patients with Pickwickian syndrome, maybe undiagnosed Pickwickian syndrome.
Yes.
So then maybe GLP-1 can be also helpful in Pickwickian syndrome.
Maybe yes,
okay.
But there are nothing data for this population. So the the obstructive sleep apnea, we only have 5 articles to investigate this, the GLP-1 analog, so it's not too much space we can research this. So we need a lot of more research in this topic.
Thank you. Well done. Thank you.